Well, hello everyone. Welcome to Friday's report. Good to see you all. We've got an important report out today. One to see how our do all about reducing the department to children's hospital. So we've got the pediatric ED team. I haven't got a list of colleagues presenting. Maybe you yourselves as we go, and very much looking forward to it. So over to you guys.
Hi, I'm Helen Mollard. I'm the lead clinician for paediatric emergency medicine at Leeds. So I'm going to start the report out about the event we've just done in the paediatric emergency department. And then I'm the sponsor for the event. And then Katie, who's the process owner, is going to join us, Katie Lambert. And then some of the other team are going to present some of the slides. So welcome everyone, first of all, to this. What I want to talk through is the event we've just done this week, which was done on Monday and Tuesday, which we did reducing delays for patients referred from the emergency department to the children's hospital. So can I have the next slide, please? So the challenge we set was to improve patient flow by reducing the time taken for a paediatric patient to be referred from the emergency department to a specialty, and then that patient leaving the department. Now, this actually factors, it sounds quite a simple process, but it actually relies on quite a few different things. So things we're looking at is when the clinician makes a decision to refer a patient, how that goes about, how then the communication is done with the patient going to, with the communication with the nursing staff of how to TCI the patient, how then that is communicated to the bed board and the patient flow people to start looking for beds, and then how we prepare our patient for the beds as well. So things like repeat our currently swabbing patients for COVID and getting patients ready to go to the wards. So although it seems quite a simple process, it does rely on a number of factors, and we wanted to start to do this more efficiently. Why did we think this was important? Well, patients are told they're going to a ward and then, or to the children's assessment unit, and then can sit in that cubicle for up to a couple of hours. And that time to patients is just waiting, really. So it's not a great patient experience. We want to improve the patient journey through our department. But also from an emergency department perspective, we know that maintaining flow is vital to our department functioning and providing care for ongoing patients who are coming through. So we want to make sure that we maintain flow and get patients out in as prompt a fashion as we can. Next slide, please. So the data collection was done in two separate ways. So another challenge we had was we actually started all this work pre-COVID. So we were due to do the event back in March 2020, and then that was obviously put on hold, and we completed the event this week. So we had done some data collection before the event was due to go ahead, which was quite useful, really, because the paediatric emergency department, unlike most areas, has not been stretched by COVID. Just children's services have fallen off quite a lot. So we did some data collection back in February, March last year. To do data collection now was more challenging because the KPO team were not allowed in our department, but instead we found a way around that by training up some of the clinical fellows from the paediatric team and the emergency team and training them up in data collection. So the KPO team were very good at doing that and training them up, and thanks to our fellows who helped out by collecting that data. So next slide, please. So we looked at time taken from a decision to refer the patient in to the child going to the children's assessment unit, and we found it's 34 minutes and 31 seconds on average, and that was that was the current number. Pre-COVID it was 40 minutes. Which isn't actually that bad. We know we don't have huge amounts of problems in getting them up to the children's assessment unit because the beds normally are available there, but we thought we could still improve it. We did also look at the time it takes from a child who's referred direct to a ward, which is what we try and do if we know that that child's going to be staying in more than 24 hours because they don't need an assessment unit, they need a bed. That time actually was over 2 hours. There's definitely some work to be done around that as well, but we felt that was slightly a larger piece of work, and because we'd had to reduce the event to 2 days, probably out the remit of this event to a point. Next slide, please. So our target was to get this down to 30 minutes, which is not a great reduction, but to be honest, if we could get it even lower than that, it would be good as well. So that we looked at that. Next slide, please. So some of the things that came up in the Kaizen burst, when we were looking at why there was a delay from when we referred to when we TCI them in. Firstly, there's quite a variation in this, and some of that is to do with who is referring the patient. When the TCI goes on symphony, so the doctor may decide to refer, but that communication is not great with the coordinating nurse, the patient doesn't get TCI'd. And sometimes there's a clinical reason for these delays as well. We recognise often very early that a patient might need to come into a bed, but they may not be clinically ready to go to that bed. So we may TCI early to get the process started, but the patient might not be ready to go then. So that was one of the things we focused on. Next one, please. So again, whether we had the colleagues there to act or to advise on this. So we run the PDD with a nurse in charge, but also a coordinating nurse who's the coordinating nurse in charge of flow. We don't really have flow coordinators just for the PDD. So it was about whether that coordinating nurse was always available, whether you could communicate to him or her correctly that the patient needs to come in, and whether we had the right clinicians on as well, because like I explained, some patients will go direct to the ward, and that depends on having the right seniority of clinician there who've got that authority and the knowledge to be able to do that. Next slide, please. And finally, we looked at portering, which is quite a large aspect of obviously getting children out of the department and to the right area. In busy times, we can wait up to an hour for a porter to arrive because obviously their service is very stretched as well. We looked at whether we needed porters for everyone, who needed nurse escorts, and whether actually some children and their families could just make their way up, because some of the feedback we had from parents was, and we get, to be fair, quite often, is we can just make our ways up if they're waiting a long time for a porter. Next slide, please. So as I said at the beginning, really, from a patient perspective, when they're sat in that cubicle, when their clinician said, we're going to bring you in now, we're going to let the paediatric team see you, and then they don't see or hear from anyone else for maybe an hour or so, that just seems like waiting. And whilst, as I mentioned, a lot of things are going on behind the scenes there in obtaining that bed and getting the patient ready, to the patient and their family, that just seems like waiting, which doesn't really seem like value added to them. Next slide, please. So we looked at patient experience, which was great because mainly it's very positive in all aspects, but there were obviously some people who weren't as happy, and something we can improve on. Next slide, please. And these were just some of the comments from the patient experience. So overall, a good experience. Sometimes people agree to things just because a medical person said it should happen, which I'm sure is true. And quite long gaps between, again, you know, that a junior doctor may have gone in to see them. They may want to come out and discuss with one of the seniors. That senior is busy with other things. So to the patients, when they're just sat in that cubicle, it just feels like a huge amount of time just waiting and waiting because they can't see the process that's going on behind the scenes. Next slide, please. So I'm going to hand over now to Katie Lambert, one of the Band 7s in PDD, who is the process owner for this. Thank you, Katie.
Thank you, Helen. We had teams from both the ESM, CSU and Children's as part of the 2 days, and both teams managed to bring loads of ideas from the home teams to the event. We've got loads of ideas that we're planning on taking forward, but we focused on 3 areas, 3 PDSAs through the 2 days, which we felt in 2 days was actually a great achievement to have focused on 3 areas. So the first area was improving the communication between the paediatric emergency department and the patient flow coordinator or bed manager in the children's hospital. The second one was around reducing wait times for patients waiting to transfer out of the paediatric emergency department. And then the third area that we worked on was improving the medical referral process between the paediatric emergency department and the CAT unit. Next slide, please. So as I said, there was loads of ideas came out of that, and there's a large area of work that we've car parked for now, and we'll be looking in the next few weeks to be allocating to teams to work on. And there are areas around the GP transfers into the trust, and the letters that they bring with them. Areas around the ED assessment process and that assessment to treatment pathways. The ongoing conversations of the need for a surgical assessment unit within the trust, which is obviously a large piece of work. An update of the CAT attendance leaflet to give better communication to families, moving from the one area to the other. Some increased work on joint medical pathways and updates to the teams around those, to avoid more conversations occurring, and clear pathways for that patient. Another area that was brought up was around access to wheelchairs. That came out of the outside of the remit of the piece of work we were doing, but is a factor of flow within the ED department. Again, wider digital referral process, a bit more of a consistent approach for multi-specialities. And another area that was brought up was around overstock store cupboards in the department, again outside of the remit of this piece of work, but something useful to focus on that will improve flow in the ED department. Next slide, please. So I'm going to hand over to James Conroy, who was one of the team working on the days, to talk about the PDSA number 1 that we worked on. Thank you.
Thank you, Katie. Hello, I'm James. I'm one of the clinical fellows that was involved in the data collection, and then our sub-team had a quick look at outcome 1. So this was the first of the PDSAs that we looked at. We realised quite quickly through some discussion that there was actually really poor recognition of what the coordinator did in the PEDS ED from external staff and actually some of the internal staff, such as clinicians as well. And that actually a lot of information was kind of flowing through different routes and not through the coordinator in the PEDS ED. Simple things that we did to try and improve this on the sort of our first day of the rapid week was to introduce some visual prompts into the department. So we gave, as you can see in the photo, just something simple like giving the coordinator a badge to wear so that internally we could recognize who was actually coordinating at that time, and just putting up some signage to say who was coordinating. We then focused on actually trying to work out how we could better make the coordinator reachable from external people, such as the bed managers. So we've given the coordinator a dedicated phone number, sort of a carry phone for which the coordinator can actually carry around. We found that a lot of the information was going through the nurse in charge as opposed to the coordinator. And overnight after day 1, we did find actually quite quickly that this was improving things. Instead of having multiple phone calls, the bed manager overnight remarked that actually of the 5 patients that were admitted that night, only 1 conversation was required for each patient. So that was a very good thing indeed. And then on the second day, we realized that there was a sort of a negative aspect to making the coordinator a lot more compactable and more sort of visible, I suppose, in so much as actually it was making the job a lot harder. So on day 2, we decided to employ some interventions to make the role of that coordinator a lot more streamlined. So it was just things like visual prompts. So we cleaned up the sort of the task board, split it into an OBS area and a sort of a other things that needed doing within the ED, just so that everyone could kind of actually pull things as they need it to. And we also made sure that OBS were getting done automatically, as opposed to having to be prompted by the coordinator, by putting in a new process for that. I think I'm going to hand back to Katie to have a chat about the second PDSA.
Thank you, James. Yeah, the sub-team unfortunately can't attend today, so I'm filling in for them on this bit. So the second one was around the portering. Oh, sorry, next slide. Yeah, thank you. Was around portering, and as Helen mentioned earlier, that recognition of the culture that we had always booked a porter to transfer patients from the ED to the CAT unit, and that sort of recognition that perhaps that wasn't always necessary, and not only releasing speeding up the process for the patient moving, but also releasing the portering team to be able to focus on other areas of their role. So we looked at that sort of self-transfer to CAT. We reviewed the signage. The children's assessment areas moved recently, so we reviewed the signage from one area to the other and designed a map. We then identified all the patients going from the paediatric emergency department to the assessment area, and looked at those potential delays. We then spoke to lots of stakeholders. We interviewed them to establish whether that reduction in the use of porters was suitable, and we highlighted any potential concerns. Some of that was around transferring of medication, and patients getting lost, and making sure that we'd got it right around which patients were safe to transfer of their own accord, and which ones would need that porter transfer, plus or minus a nurse escort. And then the map was produced, and then we were able to, on that first evening, implement the process. We trialled it overnight, we recorded which patient we thought would be suitable in that first overnight period. The second day, we trialled that, and we were able to ask parents, do they think that they would like to go following the map? And several families on that first day were pleased to go to follow that process, and that process is continuing this week, and we're getting really good feedback from that. I'm going to have next slide, please, and I'll pass on to Charlotte to talk about outcome 3.
Hi, I'm Charlotte. I'm one of the staff nurses based in the paediatric A&E department. So for outcome 3, we looked at the referral process between the emergency department and CAT. I did that with one of the senior nurses in the CAT unit. So what we're looking at was improving the amount of time to refer a patient and then get them up to the CAT unit. So quite quickly recognised that there were some time delays when actually trying to refer to the unit. We found that the barriers in that were the registrar not having the phone on them at the time, or if they were busy with another patient, it would delay the referral process. We looked initially at current IT processes in place, such as just online referrals and looking at how that could be used. However, we found quite quickly that some things were kind of going on in the background with that, and the difficulties around producing that in a couple of days became a bit apparent that it wouldn't be feasible. We then pulled it back a bit more, so we started to look at verbal prompts between the two teams, so recognising the correct number to refer to the CAT unit, and having a visual prompt in the CAT department for the doctor to remind him that he needs to have the phone on them at all times. We did consider that some patients didn't always need to have a verbal handover, but again, in the current processes that CAT are doing, we haven't been able to pursue that any further. But we have researched into it, and we have found ways that we can do that. I've got an audit process going on for the ED department for how long it currently is taken us to refer to the CAT unit, and I'll be kind of looking at that over the next 30 days and seeing the results from that. I think that's everything for that one.
Thank you. Next slide. Thank you. So we found lots of areas that went really well over the first 2 days. And I think this is one of the first events that's been done over Teams. The staff engagement from all the teams was brilliant. It was a multi-CSU event as described, so that was brilliant that we've managed to have that staff engagement from the areas. The level of ideas from the home and away teams was incredible, and lots of exciting areas that we can look to work on in the future. I think that it was great to see that improvement in the overnight trials in each of the 3 areas that we did. And we were able to get the feedback from our colleagues in the home teams to make further changes. We've created plans going forward for each of the areas, and we had a really positive sharing with the tri teams on the afternoon of the second day, and lots of support from them, and offering of assistance in any areas that we may need assistance with to move things forward, especially in some of those car park bigger pieces of work. Next slide, please. Thank you. Obviously, with anything that we reflected on, a few things that we could have done differently. So we recognise that the in-person communication is key, and beware of handover of key messages between stakeholders. I think some of the messages we'd put in place on the first evening had gone a bit awry overnight, and some slight frustrations the second morning from some staff until we couldn't make things a little clearer about what our intentions were, and then it went swimmingly the second day after that. That recognition that buy-in is important, and listening to the concerns of the individuals and reacting to those as I've just described. And that identifying and talking to all the stakeholders. I think one of the things we hadn't recognised was about going and talking to the porters. We'd recognised that we would be taking some work from them to ease things up, but actually they came up with some brilliant ideas of things that we hadn't considered. So we definitely recognise that the greatest of ideas came from the most unexpected places. Next slide, please. And then finally, for the presentation, we're looking forward over the next 30 days positively. All the 3 PDSAs have commenced changes within those initial 2 days, and are continuing this week and into the future. We're going to review the feedback from the staff and review that impact for the staff and the patients. And we're going to be discussing the feedback as a team and agree any necessary updates to the PDSAs. That's all from us. Thank you very much. Is there any questions from anyone else?
Great. Thank you. Thank you so much. I'm aware that colleagues were having problems hearing me before. I hope I'm coming through loud and clear now. But thank you so much to Helen, Katie, James, Charlotte. Really good work. That was excellent. I really enjoyed that. There's so much really in that, and I know it's a really key area for us, and one that an awful lot of work has been going on, and really impressed to see what you've been doing. So let's open it up to questions. Who'd like to open up with any questions or comments?
Well, it's something Katie mentioned. It's possibly one for sort of us all to just. I was really struck by what you said, Katie, about involving the porters. And in a previous hospital where we've sort of been involved in a similar methodology, particularly when you're talking about patient movement and flow, we sort of learned that we needed porters pretty much in every conversation. It just reminded me of that learning from quite a few years ago, actually. I'm just interested to understand a bit more, and I guess from KPO colleagues on the call, whether we do explicitly think that through. Just your point about great ideas from possibly slightly more unexpected places.
Yeah, I think we'd because we'd made the decision to end the sponsored challenge at the point of leaving the door, we'd made the decision at that point to not have a member of the facilities team on the away team, which it seemed the right idea at the time. And I think it was only when the ideas came from the home team, the home team, around that area of waiting for the portering team, that it was obviously at that point we must have their involvement. We must speak to them, and that was one of the ideas that the KPO team helped us with. And yeah, they came up with some really good ideas that we will probably add to some of our to-do lists, which it was good to see a different angle of it, really.
Yeah, that's really good. Really good point.
And Julian, would you mind if I just circle back around at one more supplementary?
Please.
This might be me not paying attention in report out, so please tell me if I've missed this. But do we think, therefore, I don't recall seeing many of our estates and facilities colleagues reporting out at report out, and again, just wondering whether we do it, we involve them in that enough as well. And again, it's slightly broader than your remit, Katie, so this is me thinking out loud, really, rather than...
It's a good point, Jenny, actually, and I know we have had a number of the we have had porters involved in some of the work previously you've reported out, but I think there's a broader point now. I think, Jimmy, did you want to come in on that?
Yeah, thanks, Julian, Jenny. It's a really good question, and part of the setup for all these events does include a question about who are our stakeholders. And I think we're getting pretty good at knowing our patients should always be part of the conversation. That comes through loud and clear. But I think you're quite right, Jenny, in terms of asking that question. I don't think, for me, we are blind to the benefits of bringing our colleagues from estates and facilities in. As Julian's just referenced, I can remember a colleague, Philip Sutcliffe, who was really helpful in a piece of work we did with the theatres work, which is a while back now, as many are. But perhaps your point does bring it a little bit more front and centre about how they should, it should be, why wouldn't we involve them, as opposed to have they got something to offer? And it's maybe just changing the way we ask the question of our colleagues as we're preparing these events.
Absolutely, Jimmy, agree. Can I just check then other questions or comments for the team? I can see a hand's gone up, but I can't see who it is, I'm afraid.
Right. My name is Dolf Mogendorf. I recently joined as a patient volunteer.
Excellent. Welcome.
Thank you. And this was my first KPO event. And I must say that I thought the team worked extremely well in not easy circumstances, especially in terms of technology, sitting in a room, sitting in 2 rooms the second day, which was better, trying to report with technology that wasn't really suitable necessarily for the event. And I thought they did remarkably well. I mean, I was there to listen and learn. As I said, it was my first event. But I thought they did remarkably well in the circumstances, and I just thought I'd want to add that.
Thank you so much. And can I just say a big thank you to you for joining? It's really important to have our patients involved in the Leeds Improvement Method. And secondly, thank you for your comments about the team and how it worked. That's really good to know. I had a question actually for the team, just about the interface with CAT, because of course, I'm sure we all know we officially opened the new CAT unit and the Countess of Wessex did the honours, which was nice, albeit all virtually. But has that made a difference, and how have you factored in that change in location and space around CAT in terms of some of the transfers and interfaces that you were describing? And has it improved your experience for patients?
Helen, do you want to chip in, or do you want me to?
Yeah, no, I can. Thanks, Katie. I think, in all honesty, we haven't really had to test it yet because of how we have been fortunate. You know, children, when they don't mix and get to school, don't get poorly. So you know, we recognise we've not been as tested in some ways this year as certainly other parts of the trust have been. So I think we've not had that sort of test that we had obviously back in winter 2019 when we had an incredibly difficult time. I think it's brilliant though, because we all recognise that when things start to pick up, as they actually have done the last week or so, our numbers are hugely up from what they were even a couple of weeks ago, as are the CAT, because obviously that's reflected. I'm sure it will make a big difference. And we know, looking at data coming out of kind of Australia and New Zealand, that they've had a pretty bad time post kind of their restrictions, with children becoming really unwell, a lot of bronchiolitis and RSV. And I think our main job now in the next few months is to get ourselves ready for that coming into next winter, and our pathways, and using that extra space we've got and using it efficiently, so we're not back in where we were kind of a couple of years ago in winter, really.
No, absolutely. Absolutely, Helen. Thank you. And just a supplementary, the extent, I get a really good sense of the level of teamwork here and collaboration, and the sort of the sharing of the journey on this. How have you engaged with the wider, the sort of home team and the wider group? Does that feel good in terms of their engagement, and obviously important, I guess, in terms of the sustainability and ongoing development of this work?
Yeah, I think there was good engagement from all around, and we recognise that, you know, we are quite physically distant from the CAT unit, like you mentioned, and the new CAT unit is even more physically distant from us. And I think that does sometimes hamper things, and we recognise that, because we would like to have more joined up working, because a lot of our work overlaps hugely. So I think bringing an event like this and the opportunity to bring everyone together, and, you know, it's been very difficult recently for that face-to-face interaction. We know actually helps relationships hugely, and some of that has been a bit lost in the last year. So I think this allowed that, and some more face-to-face engagement with different teams, because as well as the CAT team on this, we also had someone from the patient flow coordinator team as well, who play into this. So I think allowing that, and people from different teams then engages all their own teams back in their departments, because they can see that they're part of that conversation. So I think it has worked, and it's reopened up some conversations that we probably need to start having, like I say, getting ready for what's probably going to come. So there's a lot of work to be done, but we have it's highlighted that to us, I think, more, and we know where we're going now in planning for next winter.
Great, that's really good to hear, Helen. Thank you. Well, I think we're just over time, so unless there are any final questions, let me just check. I can't see any, in which case, can I just say what a fantastic job you've all done, and I'm really delighted that you found the time and space to run this event. So important that we've kept the Leeds Improvement Method going throughout the pandemic. I think we all feel a little bit more optimistic about the fact that numbers of COVID patients are declining. But as Helen was saying, that has a consequence in terms of being more busy for children, particularly as schools are back and there's more mixing going on. However, my sense is we're really well prepared and equipped, given the work that's been done, and that's really great to see. I'm also looking forward to the fact that perhaps over the coming weeks and certainly months, we'll all be able to mix a bit more around and about the hospital and get to places. And I'm looking forward to seeing for myself some of the great work that you're doing. So really well done. Thank you for reporting out today. Please keep coming back to report out with updates on how things are going, because this is such an important area for us. And thank you everyone for joining today's report out. And I very much look forward to seeing you all same time, same place next week. Thank you everyone. End of report out.